Issues sometimes come up when you have multiple clients. How do you keep those records? If one party wants records but another party doesn't, can they get the records of both parties? The answer is no. No one can waive privilege for any other person. Say if a couple divorces, the husband wants records, he can only get his own records, cannot get the records of his wife. Let's say he's trying to prove that the wife is mentally ill, only the wife can waive the privilege for those records. The only exception is if the husband were to go and get a court order, convince a judge that it is critical for the welfare, the well-being of the children, that the wife's records documenting her mental illness come out. Then maybe, although it's probably unlikely that the judge would grant an order.
But sometimes the judge will take the records in camera.
That's correct, right.
And actually review the records and strike out what the judge feels is not relevant to the case in hand and leave a few things in.
Right. And you generally have to resist efforts of one member of the family to gain another party's records. And you may be subject to all sorts of pressures. I remember an attorney, I had refused to release the records. I had an attorney, I believe it was the father's attorney, call me and saying, well now, doctor, of course the only thing we're interested in is the welfare of these poor children. And you really do have to release these records if you want to protect the welfare of the children. Thank you, I'm sorry. I can only release it if I have the wife's signature or a court order.
Interesting, and we have another case coming up right now, which is a little bit more complicated, and I'm going to put it out, and I'd like your comments on it too. What if you're the therapist of a group of 15-year-old kids, and one of the boys in the group shoots and kills another person? What records can you release? His attorney says, I want the records. The state who's prosecuting the child says, I want the records. What can you and can you not release? This is a group now that you're seeing the child in, not individually.
Good question. Why don't we just defer it to the lawyer? But I would suspect that you would take the stand that take the stance that you can only release the records of the person who has authorized the release, and that any other records you would have to have a court order in order to release. I suspect that is the most conservative course of action.
Well, that's good, but one other thing. He's 15 years old, so he cannot release them himself. You have to have the parent also sign. So, and some states you have to have both parents sign if the child has lived with both parents. And in some cases, if the child is a ward of the state, or the state has taken custody of the child, then it's the state agency. Now you've got a real problem because the state may be more inclined to support other state workers in prosecuting the young man.
All the more reason to get an attorney to give you advice.
And all the more reason to not overwrite in your notes, to be very careful what you write, especially when you're doing groups. There are guidelines for what kinds of records to keep when you're working with a group, and I'd strongly suggest those of you who are doing group work, if you haven't looked at those guidelines, you really need to do so that you can have the appropriate notes in the file with the group, because you have to be very careful that you don't release any of the confidentiality of any of the other youth who are in that group with you. So it's very complicated.
Very complicated. And the one final point I want to make, since you brought up the issue of violent behavior, is the whole issue of what is sometimes called the duty to warn or duty to protect third parties. It is tremendously misunderstood, but you really have to look at the case law in your individual state. In this state, the state of Florida, the so-called duty to protect third parties is discretionary on the part of the psychologist or the therapist. You do not have to do it. What you have to do is a careful assessment, which will then inform your decision on how to handle the situation. If you can handle it clinically, fine. If you can get the person medicated or give them more sessions of psychotherapy or get them hospitalized, and you can document that in your clinical judgment that's the appropriate course of action, then it's fine. If you feel that it's an imminent threat and the only way of handling them is to notify the authorities or to notify a third party, then you do that. But whatever course of action you take, you have to document why you have chosen that course of action. Other states require you to notify a third party. State of California requires you, when there is a threat from a client that you're seeing, it requires you to notify either the police or the intended victim. So be very careful on this. Don't generalize from one state to another. Make sure you understand what those situations are.
In California, you're talking about Tarasoff, I assume.
And
its progeny.
Well, Tarasoff was case law. There is now statute in the state of California.
Good, important to know.
Yeah, that says that that you must notify. What makes it even more upsetting for psychologists is that in the state of California, don't think this has happened in too many other states, is that once that occurs, once you make that warning to a third party, then your entire record ceases to be privileged. Wow. And the state can get access to the record if they want to prosecute someone.
Wow. So that's another reason why we have to be very careful about not overriding what our speculations are or anything that we don't have data to support in our records. Right. Well, let me give you one more example before we move on to another topic. It's just, again, an example of a married couple, Mr. and Mrs. Adams, who came to you for couples and family treatment. And you've been seeing them for 2 years. And then all of a sudden, even though you've done great therapy with them, they decide that they're going to get a divorce. And they both want sole custody of their 2 young children. So Mr. Adams wants you to release the records that he believes will document Mrs. Adams' use of alcohol that was discussed in sessions. And Mrs. Adams wants you to release the records that will document Mr. Adams' abuse towards her. What do you do? Well, which records can you release? Again, let's go back to what we've been talking about in terms of confidentiality of records. Mrs. Adams cannot sign to release Mr. Adams' records, and Mr. Adams cannot sign to release Mrs. Adams' records, only their own records.
Unless they were to convince a court that it's necessary for the case.
That's true. Generally, if they go to court about that, then what the court will usually do is want your records, and the judge will review the records and make the decision what is in your records that's relevant to what the court needs to know. And of course, the issue of alcohol use or the issue of abuse are both relevant in making a custody decision. So again, both of Mr. and Mrs. Adams have put their records at issue by both of them demanding the court to make the decision about who gets custody rather than the presumption in the law, which is shared parental responsibility of those children. At which point, if that's what they agreed to, nobody would touch the records. So they may call you and they may say to you, what's in my records? I want to see my records. Again, Mrs. Adams can only see her records. Mr. Adams can only see his. And so you may have to say to them, look, I've kept your records together. I will have to recopy them separately, and that I have to charge you a fee for that. And that fee is going to involve my clinical time because only I can do that. So they're incurring some expenses with that. But it's legitimate because when you see them as a couple, you are allowed to keep their records together. How's that?
That sounds good.
All right, let's move on to the last major topic that we want to cover today. And that is to reduce some of the adverse medication events that occur. One of the areas that psychologists in particular have been looking at is the ability to prescribe medication. And one of the arguments against psychologists doing that has been, well, there would be more adverse medical events. Actually, that is not true. There are actually no adverse reports of adverse medication events by any of the insurance companies or any of the other places where we keep these records. So psychologists are quite safe in terms of their ability to prescribe. Now, this is trained psychologists. There are, we think, about several thousand psychologists who have gone through master's programs or other certificate programs with appropriate training. So, in many states, like in the state of Florida, if, like myself, you have a master's degree in clinical psychopharmacology, you can give advice to your client about medication, and you can confer with physicians in the kind of medication to prescribe. So that's important for us to know. And we've got to be able to have standard protocols for that in order to be able to know if there was an adverse medical event from medication. That we would know about it. But if you use a support system and if you're very careful using the computerized analyses of medications and the interaction effects, there should continue to be high success with whatever medication work we are doing. There are also some things that we need to pay attention to. Number one, the antipsychotic drug prescriptions that are being written for children has increased 6-fold just in between 1983 and 2002. Think about that. Now, that's true that we have many more antipsychotic drugs during that period of time, but these children are being prescribed antipsychotic and other medications off-label. There's no research to show that these drugs are going to be safe for children. The FDA has only approved 3 antipsychotic drugs, and those drugs include haloperidol or Haldol, thorazine, and I can't read it. Pimozide. These are antipsychotics. They are not atypicals. And so these have serious side effects. One of the most serious side effects are the extrapyramidal responses or movement disorders. And once a child gets one of these movement disorders, it's almost impossible to reverse it. Today, very few of the major antipsychotic medications are used for children. Some may be used for adolescents, but most of the prescriptions that are written for children tend to be what we call atypicals. There's some data to suggest that almost 90% of them are the atypicals or the second generation drugs, which have much fewer side effects right now. And the ones that have been approved there are clonopine, risperidone, Seroquel, and I think Abilify. So be careful with that. Make sure if a child is placed on any of the antipsychotics, first or second generation, they should be getting blood tests at least every 2-3 months. So you need to check on that as well. The antipsychotics prescribed, most of them are for disruptive behaviors, which is really sad because for a lot of these children, as I mentioned earlier, depression in young children especially often comes out in the form of disruptive behaviors rather than in sadness or in a reduction of activities. 32% of these children do have diagnosed with mood disorders. 17% of them are diagnosed with pervasive developmental disorders and autism, and only 14% have psychotic disorders. So most of the drug prescription for children today is off-label, and school personnel need to be careful too. The confusion, for example, between children who are being prescribed Ritalin when there really are PTSD symptomatology, easy to overlap ADHD and PTSD. We need to be careful. These are system errors, not necessarily people errors, but they could be people errors, especially when the child is involved with the Child Protective Services and they're getting rotating physicians. So one physician prescribes and the next one checks up and doesn't do blood testing. So adverse medical effects are high risk in these kinds of situations. We also see some of the children being put on antidepressants, and we know that some of those antidepressants may be causing children to gain too much weight and may be causing a diabetes-like symptomatology. Again, we got to watch the symptoms. We need to watch the overprescription of the SSRIs, the serotonin reuptake drugs, because you may be the child may be prescribed them because of depression, but sometimes those drugs can cause a switch in moods to a bipolar disorder. I do want to just mention there's a lot of diagnosis of bipolar disorder in young children these days, and a lot of the data are not in yet. It may be the diagnosis du jour. So again, get educated about drugs, or get consultation if you're treating children. Or you're working with parents who are treating children, because so many of them are placed on medications, and we don't know what the medication, the long-term effect of the medication may have on them. So it's just an area that we need to pay attention to. It's a high-risk area. And I want to turn over to Dr. Shapiro. The two of us are going to finish up with the human behavioral factors that we haven't really talked about yet.
Okay, just to briefly cover some of these, we know that human behavior involves unintentional and unpredictable behaviors at times that can result in undesirable outcomes. At-risk behaviors occur when people develop unsafe habits and practices while losing the perception that risk can occur, such as they engage in certain kinds of shortcuts. Reckless behavior occurs when a person recognizes the potential for harm, goes ahead and commits the behavior anyway. But the majority of medical errors, as we said before, is not a function of negligence, lack of education, or training deficiencies. Rather, they are related to system factors, to system errors. Sometimes these system errors interact with these individual factors. Sometimes they do not.
All right, let's look at the implications now for mental health professionals as we close this webinar. We need to be sure that we develop an awareness of childhood and adult medical and psychological disorders. We need to know the whole range. We need to know about abuse in adults and children and what kinds of remedies are available for them and referrals. We need to learn about medications and drugs and what kind of side effects they may have on people.
We need to, as we said before, maintain records, document all contacts with clients and collateral sources, screen for depression, suicidal behavior, and ideation, and perform appropriate risk assessments.
We have to become sensitive to child rearing practice in cultures that may be different than ours, or that may even look like they're physically abusive. We have to remember that cultural relativity is not appropriate in the United States. If we have laws against abuse, even if it's in their own culture or their own country, they would be permitted to physically abuse their child for discipline. It doesn't happen here in our country. We also need to look at access for substance abuse that may be contributing to the client's difficulties. We haven't talked much about substance abuse today, but this is an area that often causes comorbidity with mental health disorders.
And we need to pay attention to the client's constitutional rights and make sure that we protect confidentiality and privilege, except in those very, very rare circumstances when privilege is waived or confidentiality is waived, such as in the mandatory reporting scenario.
And finally, we need to develop a referral protocol for all the various high-risk issues that we've talked with you about today. Thank you.
Thank you very much.